you would want to pick the parts that are relevant to the people in front of you, and you can skip other parts that are not relevant to the people in front of you. So if a person, for example, their baby didn't wake up in the morning, and they have their clothing on, and they have shelter, and they have food and water, and they don't need any sort of safety and comfort needs, and they don't need psychostabilization, so we can skip those steps and go straight to the later steps of psychological first aid. We can see what practical assistance they need. We can give them coping skills. We can give them information on coping about future symptoms that may arise and psychoeducation. We can connect them to further resources, okay? So we would go learn models of psychological first aid and then pick the parts, the modules, the pieces that are relevant to the people in front of us and skip the other steps, right? Another really unique thing about psychological first aid is that it can be given in a field setting. And so we can give psychological first aid in the middle of the street. We can give it in a bomb shelter while bombs are falling. We can virtually give psychological first aid anywhere. In fact, I'll say something really fascinating. When I was the director of a previous position that I had in Israel's psychotrauma unit and crisis response unit, I was the national director of that unit for a number of years. So one of the interesting things that a person before me who led the unit developed was the idea of bringing a pop-up tent to the side of a trauma incident, so that even if there's no private place to do psychological first aid, you pull out this little tent, it pops open, and all of a sudden you have a clinic. You take two little foldable chairs, you sit down, and now you can shield people from the bystanders and onlookers. It's not cold inside. You can focus with the person and you can talk with them in a way that they're not distracted and they're not seeing traumatic views. They're not seeing body parts or blood or sirens and lights and all sorts of very traumatic content. They're able to go inside and feel a sense of safety. And in that place, you can give psychological first aid. And so that was very, very creative. But the idea is that psychological first aid can be given virtually anywhere, at sea, at land, in the air, on the phone, which maybe we'll touch on later. It can be given telephonically on the phone. And it can even be given in writing. It can be given in video. And so it's very, very helpful, psychological first aid, and it can be given anywhere. The next thing is that psychological first aid can be given by people who are trained in psychological first aid. And so, you know, a psychologist can take 7 years to train, 10 years to train. A social worker can take 5 years to train, 4 or 3 years to train. A person who is very proficient and good in psychological first aid, it can take a week to train. Of course, they need maintenance, they need continuing education, they need some supervision in order to be really, really good. And this is the type of thing that I do for a living at psychotraumaunit.com. I train people around the world in these things, but you can take anybody and train them in psychological first aid. So you can take teachers, you can take doctors, lawyers, bakers, tailors, you can take anybody that is a good candidate for knowing how to approach people in the right way, and they're good people, persons, and they're able to empathically understand people, and they're able to be respectful to people, and you can give them professional tools to know how to give psychological first aid. And when you do that and you train people in advance before trauma events happen, you've just made use of tremendous resources. Just like in COVID-19, people in the country that I lived in were trying to get the vaccine, but there weren't enough people to give the vaccine. So what did they do? They decided maybe they'll use veterinarians. Maybe they'll use emergency medical technicians and paramedics. Maybe they'll use nurses. Maybe they'll use all sorts of people that don't usually give vaccines. And by doing that and training people who have some sort of connection to medicine, there was enough people to give vaccines. So too, we can take people who have a connection to people that are good with other people, they know how to talk to them and to listen, and to really bring them to a professional level of giving psychological first aid. And psychological first aid is tailored for particular disaster needs. And what that means is every single disaster has different needs that you may anticipate. So after an earthquake, probably a lot of people don't have a place to live. They don't have privacy. Their stuff might be getting stolen by other people, and they're worried about that. They don't have any belongings. They're worried about their loved ones. I remember a case of arson, another arson case, and this happened about 2 years ago, I think, where a man with pyromania, so he had a compulsive desire to set things on fire, pyromania. He took a book and ripped out the pages and lit the building on fire using these pages of the book. And he decided for no reason to impulsively set a building on fire. Also, it was about 4 a.m. and he just lit a building on fire. And at 4 a.m., people woke up, and this was a massive building with many families and many children, and people ran for their lives, and they jumped out the windows, and other people sheltered in place, and the firefighters had to fight this huge, big fire. And thank God it was miraculous, but nobody was killed. Nobody was killed. Some people had smoke inhalation. There were some light injuries because people jumped out of windows and hurt their legs and things like this, but nobody was killed. And when I worked on that scene, so I ended up speaking to about 50 or 60 people from that fire in the week to come, giving psychological first aid. And most people had very hard difficulty falling asleep. Because can you imagine when you're in the middle of sleeping and all of a sudden smoke detectors go off and there are loudspeakers and firefighters screaming through your windows, breaking down your doors, pulling you out of a fire? That's frightening, it's shocking, and it happened while you were sleeping. Now, in order to fall asleep, we allow ourselves to be relaxed and to feel good and to fall asleep, right? But now everyone was hyper vigilant, which is a symptom of trauma, anticipating there would be danger and a fire instead of letting themselves gently fall asleep. So how do people fall asleep if that's what happens when they're in the middle of sleeping, that fires happen? And especially when a pyromaniac made the fire, it's even worse. It wasn't just an electrical fire that happens to have happened because it was old equipment or something. It was a person with intent that walked up to their building and set it on fire for no reason. So it's a person with mental capacity and intent that set their building on fire, which makes it even more traumatic. Studies tell us that interpersonal interactions like this type, where somebody hurts somebody else on purpose, is even more frightening and traumatic. So in that case, most of the people I spoke to, men, women, children, had a very hard time falling asleep. And so one of the things that I tried to focus on was also speaking about how to work with sleep issues and to fall asleep. Okay, so psychological first aid is not only given modularly for people's needs, but it's also tailored for the particular needs of a particular disaster. Here's another really important thing. Psychological first aid does not assume psychopathology. We don't assume that people are broken and that they have severe trauma and now they all need therapy, and if they don't get it, something bad is going to happen, and so on. Okay, I'm going to run along. Now that we spoke about psychological first aid, I want to make the main point that I think is really, really interesting, and that is psychological first aid, let's say, is a certain framework. It's a certain way of thinking, a certain set of professional beliefs, which is evidence informed, that we use to help people right after disaster and traumatic events. And I think that the beliefs that create psychological first aid and make it what it is allows us to integrate mindfulness and acceptance and commitment therapy components. And I'll show what I mean. Because psychological first aid does not assume psychopathology, and because they view acute traumatic stress as a normal reaction to an abnormal situation, this allows us to use ACT and mindfulness-based components in our work. Because In those models also, they have something that we'll see soon called destructive normality. Destructive normality. In other words, it is normal for people to feel hard and rough feelings, and thoughts and feelings are transient, they come and go. And when we try to control those feelings, that makes those feelings even more maladaptive. It makes our way of showing up to trauma even worse. And so that fits in really, really well with the way that psychological first aid views acute traumatic stress. Because we tell people in psychological first aid that what they're feeling or what they may feel in the days to come, at least for the next 3 or 4 days, it's really, really normal to feel frightened, shocked, angry, sad. You can't stop eating. You don't want to eat at all. You can't sleep at all. You can't stop sleeping. All those things and more, feeling numb, feeling guilt, feeling shame, all those things are very normal to feel right after a trauma event. It's so normal that it's not even in the DSM. And if I recall correctly, it's not even in the most current edition of the ICD-11, because it's not a psychological, pathological problem to feel trauma after a trauma event. It's a normal thing that normal people feel. Something bad happened, you feel bad for a few days, that makes sense, right? So we educate people that these feelings come and go, and that most of the time people are resilient, these feelings go away, people come back. And so this is compatible with the assumptions, let's say, of acceptance and commitment therapy and mindfulness, which we said it's normal for people to feel stuff. They feel depressed, they feel angry, they feel worried, they feel anxious, they feel vigilant. It makes sense. It's adaptive. It's normal. You're not broken for feeling these feelings. And the problem isn't that you're feeling those feelings, but that you're trying to control it, which then limits your behavioral repertoire, your behavioral choices. That's the problem. You're trying to control your feelings, and now you're so busy with that that you can't live life itself. And in ACT therapy, for example, the goal is not to reduce symptoms, but to live with vitality, to make choices that bring us happiness, joy, meaning, fulfillment, and to make value-based choices. And even if those choices bring more symptoms, we don't care, because we're not trying to reduce symptoms. We're trying to live a meaningful life, and that is the treatment and response to trauma. Okay? Acceptance and commitment therapy is one of my favorite models because it is also a transdiagnostic model, which means I learned many models in my life that they are fantastic and they're excellent, but for one particular issue. So you have special models for addiction, special models for depression, special models for marriage counseling. And that's fantastic for marriage counseling. And maybe if you only do marriage counseling and most of the time you have people without co-occurring problems and without dual diagnosis, so no problem, right? In disasters, and I think in most cases in any area of clinical psychology, people have several problems at once. People have anxiety, people have trauma, people have depression, people have marriage issues, all at once, right? People have all sorts of things happening all at once. They have all sorts of trauma symptoms all at once. They have relational issues and a trauma symptom. This one causes that one. They work together. So you want a transdiagnostic approach, which uses the same principles to help for all types of issues that arise. So now it doesn't make a difference. It's a marriage issue. It's a trauma issue. It's depression. It's anger management. It makes no difference. We're going to use the same principles to help with all of the problems because we're attacking the issue on the level that we can come back to the metacognitive processes that help people deal with all sorts of thoughts and feelings in a more flexible way. So that's why I like ACT therapy. And that's why it's great for disaster work too, because when you have people who just lost a baby or their house just fell down in an earthquake and all their neighbors are missing and all their belongings are missing, they have many needs and many psychological difficulties. So you want to use something that addresses all of them. So ACT therapy is very different than a problem-specific approach, like we just said, that it only helps for a particular issue, or problems or approaches that aim to reduce symptoms, or approaches that are very existential and philosophical. Because right now, a person just lost their house, they can't think straight. They have so much on their head. They're so overwhelmed. You can't get too deep and philosophical with them right now. Their baby didn't wake up this morning. So you need something that's very simple and very direct, right? Or you have an approach which is great, but it takes a long time. It takes 3 years. Well, you don't have 3 years. You have half an hour. You have an hour, maybe 2, but you don't have 3 years. You don't have 2 sessions with them. You have 1 shot to help them, right? So those types of approaches may be great for psychotherapy, but not for disaster work. So here's just an example of one of my favorite models of psychological first aid. And as you'll see here, there are 8 steps or 8 modules, 8 components, and we will use different components for the different people in front of us as needed. And when will I use different mindfulness or ACT-based interventions? It will be during psychostabilization, during that module of psychological first aid, during the module where I'm trying to help a person come back to themselves into the here and now so that they're not hypo-aroused or hyper-aroused. I might use some sort of intervention